Welcome to the Aortic YouTube channel. You're watching the African-Carribean Research Corner. I am Professor Flakemi Odedina, one of the scientists anchor for the channel. I also have the privilege of serving as chair of the Aortic Research Committee. I am really very excited about the segment that we have today, and I am excited because we are talking to one of the consortia that I belong to, and this time around we're going to be talking about the African-Caribbean Cancer Consortium. And we have a guest, one of the PIs in Africa for the AC3 Consortium, Dr. Andrew Gachii. Dr. Gachii, welcome to the program.
Thank you very much, Professor Odedina. I am privileged to be with you tonight.
Okay, wonderful. Could you tell us a little bit about yourself? Before we
thank you. My name is Dr. Andrew Gachii. I am a pathologist practicing in Nairobi, Kenya. Nairobi, Kenya is on the eastern part of Africa. I have been a practitioner of pathology for the last about 24 years. And I'm really privileged to talk about, I have a lot of interest in prostatic research, and I'm one of the members of AC3 Consortium Group.
Okay,
so
awesome.
Welcome into our talk.
Yes, awesome. So tell us a little bit about the consortium.
Yes, thank you, Professor. The AC3 Consortium is the abbreviation for African-Caribbean Cancer Consortium. It is basically a research group that was that started way back in May 2006, and under the leadership of one Professor Lajin Camille from Philadelphia. And out of her vision, she came up with this idea of how we can collaborate to look into those risk factors associated with cancer in people of African ancestry. The idea is she recognized there is a gap in terms of research in these areas whereby people of African origin have not been left out. And we don't know whether the kind of cancers they are suffering from is the same cancers that are seen among the European or the white Americans or any other group. And therefore she came up with this consortium, basically involving Africans in Africa, Africans in America, and also in the Caribbean. So, and hence the AC3.
Yeah. And I have to say, I am proud to say that I am actually one of the founding members of the AC3. So I was at that meeting in 2006.
Thank you very much. I do welcome. You together with Camille have done a great job.
Thank you.
Yeah, thank you.
We are proud of the AC3. So can you tell us a little bit more about why the focus in Africa? Why is it so important for AC3 to include Africa sites as one of the consortium sites?
Well, thank you, Professor. First of all, one of the things that you note is that we have a lot of interest in what we are calling the disparities of cancer among people of African origin. And therefore, when you're talking of African origin, you can't talk of African origin without talking about Africa, because the majority of these people actually originated, or their roots are in Africa. And in particular, when you look at the immigrants, people who went to America, those ones who went to Caribbean, basically they came from Africa, and especially from the West Africa, but also from other parts of Africa. So when we are talking of those risk factors in cancer, for example, it could be viral, could be bacterial, it could be genetic. You can't really fully discuss them in any part of the world without including Africa, and hence the importance of that. The other important aspect is the fact that in Africa, realistically, we are lagging behind in terms of research. There is so much that is happening outside. And probably there's very little that is happening in Africa that we are kind of left behind, and that has created an immeasurable gap between, and hence the need to look back and say, without including the Africans, then we will not be able to know whether we are dealing with the same, for example, prostatic cancer, or is it a totally different disease?
Very well said. And, number one, also, life begins in Africa, right? Like,
Certainly is.
Started in Africa, and so to be able to understand the majority of the diseases, we really need to look back into Africa. So can you tell us a little bit more about, within the past 10 years, what are some of the key research findings by your consortium?
Thank you, Professor. One of the things that we have actually found is the fact that, and in particular, I'll talk mainly about prostatic cancer, although the consortium also is involved in other cancers, like, for example, women's cancer, and in particular, breast and cervical cancer. But also, we are interested in the cancers of the aerodigestive system, the head and neck tumors, as well as other cancers. One of the things that is becoming quite interesting is the fact that we are probably finding that the disease that we are having in Africa might be slightly different in terms of its presentation, in terms of its progression, in terms of its response to treatment. And therefore, what we think is that the approach in terms of treatment, in terms of prevention, should be different. One of the areas I have keenly been interested in is looking at the molecular signature of prostatic cancer. And actually, we are finding there are certain genes which are very unique to the African population as opposed to, for example, the Caucasian or any other group. In other words, we might be dealing with a totally different disease, although in terms of presentation, it's more or less the same. One of the other things that we have also found is the fact that, and probably this has to do with the time of presentation, is that, of course, the disease most of the Africans present with is a bit more advanced. Unfortunately, most of it will come in the with the metastasis, or it has already spread. In other words, what we are finding is that much as we are calling it prostatic cancer, for example, it might be a slightly different disease. And one of the areas that right now we are doing a bit of research is looking at the microenvironment of the tumor. Within the prostatic cancer, we are looking at the non-cancerous cell, and we are finding that the pattern is slightly different from what is being found among the Caucasians. For example, certain types of lymphocytes that we find within the cancer, their numbers, for example, we have found like the T cells are markedly increased as opposed to the cancers within Caucasians. So these are quite interesting findings, and we think they will have a lot of significance when it comes to treatment as well as prevention. So we have found very interesting findings, and actually, with the help of NIC and NIH, we have done a lot of publications. Probably the consortium has published over 60 papers, which is quite remarkable. And most of these is based on the differences that we have found between the type of cancer we find in Africa, the type of cancer we find in America, and the differences in racial groups. And that has been quite interesting. And I think that's why we need to enhance research, especially in the African soil.
Very well said. You couldn't have put it much more better. It's so important to have those research within the African soil, and more importantly, by African investigators. That is so important, and that's what we need. You've answered, the next question, very well, which is to kind of look at what you see as the impact of your consortium to the prostate cancer disparities in Africa. Do you want to add anything as what you have seen so far as the greatest impacts that the AC3 has made with respect to science of prostate cancer disparities in Africa?
Yes, thank you, Professor. As I've said, actually, we have found very interesting findings. And actually, one of the things that we are finding is that because of the, probably because of sometimes of the rate presentation, we are finding that the screening aspect of cancer is one of the areas that we are missing so much. We need to look deeper into the issues of screening, and in particular, when we talk of the use of prostatic service antigen, that is PSA, we even don't have probably what we would call the age that we would consider. Most of the figures that we are using probably were done, the so-called normal values were carried out among the Caucasians. We need to do a widespread and probably very intensive screening to find out what are our normal levels for different ages. What do we consider it to be normal? When we say the PSA levels are raised, what figures are we talking about? Because we have even found that in terms of presentation, when we talk of cancer presenting when the levels are probably 10 nanograms per liter, Africans will present probably when the levels are slightly less. And therefore, what we are saying that there is so much that needs to be done, right from the screening to the actual diagnosis, even to the issue of prevention. So there is a lot that we have done, but we feel there is a lot more that needs to be done.
Absolutely, absolutely. So are there other current research activities that is going on in the AC3 in Africa, apart from what you described?
Yes, actually there is a lot that is happening. Right now we are carrying out a study in collaboration with the Caribbean, and we are trying to look at what facilities do we have on the ground. For one of the main problems that is associated with the diagnosis, the treatment, and generally the management of cancer is actually lack of facilities. And actually what we are trying to do is we are looking at what facilities are available. How can we enhance the management of prostatic cancer? But that starts by looking at on the ground. For example, how many urologists do we have in the country? How many pathologists do we have in the country? How many biomedical people do we have in the country? In other words, we are trying to go back to the basics before we do very high level research. We want to see what is on the ground, because that is actually lacking in the African setup. So we are doing a research, and we do hope that soon and very soon we'll be able to get some findings and probably be able to publish on what is the current status in terms of diagnosis, in terms of treatment, and even in terms of prognosis of cancer. Yeah. Another thing is, of course, we are also involved in the Iron Man study that is ongoing. I think my colleague talked about it. And again, we are also very excited because we are looking at the metastatic cancer. So there is a lot of excitement, much as we have realized that there is a lot that needs to be done. And we do hope that with the collaboration, and we really appreciate what your organization is also doing in terms of collaborating. I think through your organization, I had the opportunity to meet some colleagues from Nigeria, and we realized that really there is a lot that we need to do. Probably the amount of research that is being carried out in Africa, especially on prostate, is probably less than 10%. We need to do a lot more. But I think at least there is a beginning. We have some serious researchers in our country and in a few other countries, and we think the sky is the limit.
Yeah. You really, I'm so proud about how you are championing the research in Africa and the needs to be able to elevate research in Africa, which takes me to the next question, right? Yes. You talked about the capacity building, you've talked about the need for infrastructure, and it sounds like you're doing a needs assessment right now as to what do you have with respect to cancer care, with respect to cancer research. One of the things that is critical for Africa is increasing the biomedical research workforce, right? So yes. Some of the things or the achievements of your consortium in the area of increasing biomedical research workforce.
Yes, one of the things that we have realized as AC3 Consortium is the fact that we need to train a lot more. Right now, when we talk of biomedical people, for example, in my country, the population is not too large. I mean, compared, for example, to America or to Nigeria, we are just about 48 million people, and probably just half of that are male. But when you look at, for example, the number of biomedical people, for example, pathologists, you are talking of less than 100 pathologists. In terms of scientists, we are talking of probably not more than 1,000. But when you look at the population they are serving, it is so huge, translating probably to one person serving 500,000 people. So what we are saying is that there is a great need for training, especially among the biomedicals. Right now, there are a few institutions in Kenya that train biomedicals, but probably there are only about 2 or 3. And what actually we are saying is that since we may not be in a position to build institutions at this time, would we be able to get an opportunity, for example, to send our biomedicals to America, to send them to some of the key institutions in Caribbean, and see how we can increase the number. But right now, I can only describe the situation as a bit pathetic because they are too few, considering the population they are serving. So there is that need, and we need to increase that dramatically.
Yeah, and I think, that's one of the reasons that it is so important to have consortium science. It is so important to be able to have people working together through consortium.
Yes.
Just as a follow-up, what do you see? And I know, I'm not sure what, when you joined the AC3 consortium, what do you see as the advantages from working independently versus you being able to be part of a consortium and working towards addressing cancer?
Oh, that's a very important question, Professor. I must say, I only joined AC3 just about 5 or 6 years ago. I have probably attended 2 of its major conferences, one in Miami and Florida, and the other one in Jamaica. That was in October. And I must say, I have noticed a big difference in terms of trying to do research as an individual and when it's a consortium. First of all, when you're doing it as an individual, you generate data, but then you are not so sure. There's no comparison. There's no way of knowing, okay, I have gotten some data, but how does it compare with another country? How does it compare with another institution? So I have found a lot of benefits and have realized actually that the consortium is the way to go in terms of research. The key thing is it has to be collaborative research.
Yes.
And in any case, we have also found that sometimes when we work as individuals, we duplicate data, and that data sometimes is not so useful if it is not given the bigger picture in terms of research.
Yeah.
And what actually we have realized is that by pulling together the data, we get a lot more. We publish more. We make scientific progress a lot more. The key thing is consortium is the way to go, not individual research. Much as there is some room for individual research.
Yes, absolutely. You have really said it so well, absolutely. So knowing with this knowledge, there are people who are young, up and coming.
Yes.
They may be clinicians trying to get into the research. They may actually be young scientists trying to find a way to be able to, elevate their research, but they are within Africa. What specific advice would you have for them?
Very good. The starting point is, before you start working alone, try to be in a group. And the beauty of it is that may it be CAP or AC3, the opportunities are there. If people are keen to look for it, it's as simple as picking your computer, filling in a form, and you'll actually be admitted. Sometimes but the reality is that sometimes we tend to complicate things in Africa, and I think they are not as difficult. So what sometimes happens is that we don't look for these opportunities. Occasionally they do say that if you want to hide anything from the Africans, put it in a book. And I think there is a lot of truth, because sometimes we don't lead, we don't explore, we don't talk to each other. And sometimes we work in silos, in small groups or individually. The key thing is the opportunities are there if we are ready and willing to look for them. So my advice to young researchers, to young clinicians, please look for opportunities because they are there. And what I actually have realized is that the world is willing to help Africa.
Yeah.
The question is Africa willing and ready to be helped? That there is a bit of disconnect, because sometimes we think probably the world doesn't like us, they don't, but if we look for it, the opportunities are numerous. There are so many. Yeah.
Mm-hmm. I'm going to put you in the hot seat, okay? Because
yes, please.
I've been going back to Africa for a long time, right? And number one complaint that I hear from young clinicians, so this has nothing to do with the consortium now, but you know,
okay, yes,
from young clinicians and young scientists is the idea that the senior ones are not giving the young ones the opportunity, right, to be able to make use of what they know and what they are aware. And I'm not saying you, but in general, we have a lot of viewers. You know, some of our viewers would be senior scientists. What advice would you give to, number one, the senior scientists about the need to mentor and to be able to elevate the younger ones coming behind? And what advice, so that's number one, and what advice would you give to the young scientists about being able to receive the mentoring very well so that they can also elevate their research?
Thank you, Professor. There is some truth when we say that the older people sometimes are not ready to mentor. I must say, although probably I don't have the statistics, that in the African setups, people also tend to work as individuals. And it so happens, especially with the older generation, probably they were not too exposed to internet, and there is a feeling that whatever knowledge I have, I keep it to myself. The thing is, I'm not sure it really helps. I mean, if you don't disseminate whatever you have, I don't know how useful it is. So the truth of the matter is that the mentorship aspect in Africa has not been as it should be. I mean, the young people, the older people have not mentored the young people as they should. However, having said that, I think it should not also be an excuse for the young people not to look for opportunities. My advice to the older people is that, please, knowledge is only useful if it is shared and disseminated. If I die with my professorship, if I die with my knowledge, really it doesn't help. Yeah. And then sometimes we tend to think that we are immortal, that we live forever, but that's not the truth. You know, so the truth of the matter is that we must be ready to share, to disseminate, to mentor. And I think there is a lot of pride in saying, I have mentored 5 people, I have supervised 2 PhDs, I have supervised
they're like your children. They're like children, academic children.
And in any case, why are you not ready to do it? These are your children.
Yeah.
And so it is actually a golden opportunity for the older people to make sure that they actually mentor the young people. And by the way, it's the only way we can ensure that research does not die in Africa. Unfortunately, because of the level of poverty, research is never taken seriously in Africa. Of course, sometimes it is because of lack of resources. And sometimes people, especially if it's a clinician, he'll feel, I better go and make quick money from my clinic rather than spend all my time in the laboratory or in the field trying to collect data. But with the older people mentoring them, they will show them the importance of research and where it occupies in our society. And much as we are ready, we want to do the clinical work, without research, we will be left behind and we will not make any progress. Because we will always be relying on what is happening outside to treat our people. We need to develop local solutions to our problems. Yes. And that includes cancer management.
Absolutely.
So, and I'm really so happy because your organization has pioneered trials in Africa. It's one of the greatest things that can happen. So what actually we are saying is that the older generation has an opportunity to mentor, to involve the young people, but also the young people must be ready to be mentored. It's one thing to that the older people are ready to do, but if the young people are not ready to do, to go for it and to ask for this knowledge, it won't come automatically.
Yes.
Yeah. And sometimes actually we are trying to do a project and we realize it is so difficult to recruit young scientists to come in and be part of that. And the first question is, what is my benefit? What am I getting out of it? So it's a bit unfortunate, but we are saying we will continue encouraging the older generation. Please mentor, please supervise, please involve the young people. To the young people, you must get involved. You don't have a choice if Africa is to get somewhere in terms of research, in terms of cancer management.
Absolutely. You've heard the wise words from Dr. Gachii. He has summed it up really, really perfectly well. This is a great summary. This is very well done. So I will give you a chance if is there anything else about AC3 that you would like to share that we haven't talked about?
Yes. Thank you, Professor. I must say AC3 is going places. One of the things that we have now involved almost 6 countries in Africa. From Kenya, we have about 10 to 12 serious researchers. Of course, Nigeria, there are even many more. We have some in Ethiopia. So the idea is we want to increase the number. We are very excited about next year's conference, and we hope participation will be great so that we involve more people. But what actually we are also trying to do is to make sure that we collaborate. And since the cancer is a major problem in Africa, remember we have said probably 60% of the cancer burden worldwide is it's in the developed countries, developing countries. And when we talk of developing countries, we're actually talking of Africa, basically, although there are others. But it's a challenge. It's an opportunity for us, much as it's a big challenge. And we think there is a bright future for the consortium and any other consortium that would want to involve the Africans.
Absolutely, there really is. So I wanted to ask you, switching gear, very well done with talking about your consortium and my consortium. I'm part of the consortium. Are you the AOTIC? Are you a member of AOTIC?
I'm actually a member of AOTIC.
Okay, great.
Yes, I have participated in quite a number of the conferences. It's also a very good, research organization.
Thank you.
It has made a lot of progress. I was in South Africa when it was there. So
awesome.
There is, what we actually saying is that the beauty of it is that belonging to one consortium doesn't make you, not join other consortiums.
Absolutely, absolutely. And as an organization, one of the things that I ask everybody that I interview on the AOTIC YouTube is that, can you tell us what you feel are the benefits of being a member of AOTIC?
One of the things that I have actually realized is that the AOTIC itself is very, very resourceful. Another thing I have also realized is that it's mainly confined to Africa. So the things that we're talking about in AOTIC are very familiar things. Occasionally, and with all due respect, sometimes you go into some conferences in the US and other places, and they talk of very high level research, molecular signatures of tumors and all that. But AOTIC has been very realistic to assist the African scientists to look at the situation they are in. So it's about the social aspect. It's about the local things that are happening before we even go international. So I think I would encourage literally every other scientist, every other researcher, every clinician to be a member of AOTIC. And again, we are saying it's a simple thing of downloading a form and then you get recognized. So I would tell my colleagues, clinicians, and any other scientists, please, let's join, let us support AOTIC. It is our organization, we can make it grow.
Thank you so much. Very well said. Yes, AOTIC is our organization and we need to make it grow and grow as the premier cancer organization. in Africa. It's such a great pleasure spending time with you and learning about the AC3, Dr. Gachii. Thank you so much. And it is again a wrap for our corner today. Thanks for joining us. And remember to subscribe to the Aortic YouTube channel. It is free. And consider becoming an Aortic member today. Thank you for joining us, and stay safe.
Thank you and good evening. I'm honored.